Okay, so let's continue the session. So there were some technical issues, but let's continue. We won't give up, right? So we come to the next question. So I hope you all are here. Let's start. Okay, so we start with the next question. What is the diagnosis? So in this case, what do you see here? What exactly do you see here? The baseline, look at the baseline. One eye in the primary position, right eye abducted position. Now the question here is, quickly we will again look at the options to know what they are intending to ask. So what is they intended to ask? Left-sided MLF lesion, left-sided MLF and PPRF lesion, right-sided MLF and PPRF, or yeah, both side PPRF. Do we need to revise first? Let's revise. Talking about horizontal gaze center, we all know that the horizontal gaze center, if you look at this slide, is at the PPRF, right? From there, what does it do? To its same side, it is giving the neurons to lateral rectus. So the innervation is going directly to the lateral rectus of its same side and opposite side through the MLF to the medial rectus. Now instead of this, if I make a very simple diagram for you, I think life will be better. So let's do something like this, learn in my style. So this is the PPRF, let us start like this, right? Suppose this is the PPRF of the right side. Okay? So if this is the PPRF of the right side, this is going to innervate the lateral rectus of its same side. This is what we are saying. That means the innervation here is ipsilateral. So horizontal gaze center. We all understand what is horizontal gaze. Looking on this side, this is my right horizontal gaze, this is my left horizontal gaze. Right? This is clear now. So in a horizontal gaze center, what are the two muscles we have to work upon? One is one eye ka lateral rectus, other eye medial rectus. So when I am looking to the right, it is my right lateral, left medial. To the left, it is my left lateral, right medial. Correct? So how do we manage that? So when I am looking suppose to the right side, my right PPRF orders my right lateral. What about the left medial rectus? For that, PPRF is not going to directly order the medial rectus, but to the other side it orders the left-sided medial longitudinal fasciculus. And it is the medial longitudinal fasciculus which is going to order the medial rectus of its same side. This is ipsilateral. Simple? So now your horizontal gaze center is simple. It is situated in pons, it is PPRF, and this is how it works. Right. So we all understand this, that PPRF is also monitored by contralateral frontal eye field. Okay, from the other side, right PPRF, left sided frontal eye field. So this is the whole picture and this is the whole story in the most simplified manner. Hope it is clear to you. Now when there is a lesion of MLF, what happens? We all know this. Any lesion of the MLF is leading to INO, internuclear ophthalmoplegia. So what are the features of INO? INO, this is a quick revision towards that question, okay. So what are the features of INO? We all can see this. If MLF is gone, that sided MR is gone. But the other side PPRF, LR are fine, right. So what are the two features of INO? Defective ipsilateral adduction, correct, understood? So please, many of you ask me this, ipsilateral and contralateral is always towards the relation to the lesion. So defective ipsilateral adduction. So the side where the MLF is gone, there the adduction is going to be defective. And on the other side, everything is fine. So if I am looking this side, the eye will abduct, but it shows nystagmus. So you will say contralateral abducting eye shows ataxic, that is called ataxic nystagmus. Right? Now once we are clear with this, now we will come to back to the question. Now in this continuity, please understand, if same side, suppose there is a situation PPRF right side is gone and same side MLF is gone. So this time PPRF is gone and MLF is gone. Now think with me what will happen. So if this is going to, if this is the lesion, if this side PPRF, that means right abduction not possible, correct, and left adduction not possible, because PPRF is managing the left side adduction and the right side abduction in this case. Now what about adduction on the right eye? Because MLF is gone, even there is defective. So this defective adduction and abduction on one side, right, and you will say defective adduction only on the other side, isn't it? So this is what is 1.5, right. So this question, I think many of you have answered correctly. So this question is 1.5. That Morris, that is tertiary actions, not gazes, right? Difference between gaze and actions, right? So this is your, the diagnosis here would be, what do you see here? As you all have answered correctly, and very quickly how will you answer? Just look at this one. Which side there is no adduction, no abduction? It is the right or the left. So in this case it is the, oh I am so sorry, this would be the right eye and this is left. So it should be B na. This is the right eye, this is the left eye. You have to take it like this, isn't it? So if this is the right and this is the left, on the left side both adduction and abduction are gone, that means it has to be left sided MLF and PPRF lesion. So wherever both sides is gone, that side PPRF and MLF both are gone. So answer would be left sided. So it should be B not C. Okay, na? So when you talk in terms of the eye, this is your right side, this is your left side. Don't get confused. Okay? So left sided both adduction and abduction is gone, and right side only adduction is gone. So that means it has to be left sided PPRF and M. So answer is B. Correct? We come to the next question now. So this one is your INO, where the baseline you have to keep in mind the both eyes are in primary gaze at the center. On one side there is no problem. On looking at the other side, what is happening here? Defective adduction on the right side. Can you see that? So if there is a defective adduction on the right side and left side there is ataxic nystagmus. So which sided MLF lesion is this? Now you will answer it's a right MLF lesion. So here the answer is right MLF lesion. Okay, so this is a case of internuclear ophthalmoplegia. Right? Okay? Great. We come to the next. Next we come to this question. Incongruous homonymous hemianopia with Wernicke's hemianopic pupil is a feature of. I think it's a very, very simple question. Let's quickly revise our sorry. Let's quickly revise our visual pathway and lesions of visual pathway. I find this figure this is very interesting where they have shown here. So this is your, as you can see, the nasal fibers, one side the nasal fibers are decussating, temporal are not, and this is how it is, this is the visual pathway, right? And everybody is familiar with this. What are the different lesions? I am just going to draw it for you again and write it a simple way. Try to learn this way, it is more easy. So when you talk about the pathway, we generally right ka right, left ka left, isn't it? So if this is the left retina and this is the right retina, let's learn like this. Okay? Equally, I am oversimplifying. Okay, this is a simplified diagram. So this is your equally divided into nasal, temporal. We all know nasal, temporal, nasal, temporal. अब हमको पता है nasal fibers decussate, temporal do not decussate. ठीक? So this becomes your optic nerve. This is your optic chiasma. This is your optic tract. And then comes your lateral geniculate body, right? So you all have answered what? Yes, very good. The answer is A, that is optic tract lesion. So a quick revision of few very, very important questions on lesions of visual pathway. So lateral geniculate body, and then we all know fibers of optic regions, some form temporal, some form parietal. I am just drawing it in a very simple way, and then finally going to visual cortex. Okay, simplest depiction. So these are optic radiations, this is the lateral geniculate body and this is the visual cortex. Okay? Okay, so everybody should know what is incongruous, asymmetrical. Okay, when it is not in continuity, the lesion is not same on the same side, exactly the same, it is called incongruous. Okay, so when you talk about one by one, if we take a quick revision here, if optic nerve is gone, number one lesion, what are you going to get? Number one lesion, suppose I am taking the examples of left sided lesion here. So number one is gone, it is going to lead to whole optic nerve is gone, very simple, ipsilateral blindness. Okay? Then we talk about what will happen if the chiasma lesion. We all know that both nasal is gone, that means field, which field is going to go? Temporal. So we are going to get number two lesion as bitemporal hemianopias. You all know that, so I am going quickly. So how do you draw bitemporal? This is the left eye field, this is the right eye field, right? Bitemporal means both side temporal is gone. Please, the shaded part is the gone part. Now if it is, we are saying this is your bitemporal hemianopia, and then next comes your track lesion. Can you see left side temporal is gone but right side nasal. So when number 3 we have to understand is that one side where the temporal is gone will be nasal field defect, where nasal is gone you get a temporal field defect. So this is why you are getting a one-sided field defect, that is homonymous hemianopia. Okay? Now this is what we are saying, it is not, so maybe some part is missing here, it is not exactly symmetrical. Okay? So this is what we mean by incongruous homonymous hemianopia. Now you will see that whether it is the same pattern of one eye temporal, one eye nasal is going to tract, to radiation, to cortex. So life is simple. Whether it is a radiation or a cortical lesion, what we will get is a homonymous hemianopia. Okay? And as we said, what you have to understand and learn here, till anterior radiation fibers we get incongruous. After that, so if I draw a line like this, all the lesions which are anterior to the line will be incongruous, but posterior radiation, posterior fibers of the optic radiations and visual cortex leads to congruous homonymous hemianopia. You know, visual cortex is a very small area and all the nerve fibers are actually aggregating here. So any lesion, it is continuous field defect. इसीलिए आपको क्या मिलता है? Congruous homonymous hemianopia. So first you should be very clear about this. Right. Okay, so once we know this, very quickly, too much of the theory and details is not possible. I have to discuss a lot of questions, but let's go back to optic tract and see what are things we have to know. So when you say, of course we know that we have to learn in each case a lot of details in each lesion, isn't it? So very quickly, when you talk about chiasmal, we'll talk about that. We have a question on that. Coming to optic tract lesion, one is your incongruous homonymous hemianopia, you have learnt with me. What is the second important thing is Wernicke's, which is a name, hemianopic pupil. You should know this. This is an important question for your exam. So what is Wernicke's hemianopic pupil? Do you all understand? Okay. So what is a Wernicke's hemianopic pupil? When you say Wernicke's hemianopic pupil, all of you, let's very quickly understand this. Hemianopic, half of the pupil is reacting, half is not. How do you do it? It's very difficult to elicit properly. You have to be trained for that. Make the patient sit in a dark room, take a pencil torch, not a big torch. Okay? So what you are trying to do, you are showing, suppose the patient is in front of me, I am showing the light in such a way that it falls on both eyes. So when I am showing it from one direction, I see a normal reaction in both eyes. Once I change the direction, no reaction. So from one side normal, from other side no reaction at all. That is what is called hemianopic pupil. Now why do you say it's a feature of tract lesion? It's very interesting, so I will just discuss this very quickly. So see, if this is what we made just now, right? Okay, suppose there is a tract lesion here. This is the left side, this is the right side, left-sided tract lesion. What do you understand by left-sided tract lesion? What we see is, iska matlab that left side, this retina part is not working and this side of the right retina is not working. Do you agree with me? So any lesion here in the tract, this will not work, this is gone and this is gone. So this part of the retina in the left eye is not working, this part of the retina in the right eye is not working. Therefore, when I am going to show the torchlight from here, it is going to fall on these parts of the retina, I get a normal reaction. But when I change the direction of my torchlight, it is falling on these parts of the retina. So, no reaction at all. This is the reason of hemianopic pupil. Got it, all of you? Okay? So, this is the reason of hemianopic pupil. And if this is the main reason of hemianopic pupil, one eye temporal, one eye nasal, now this is a question for all of you. Answer me this. Can I get a Wernicke's hemianopic pupil? Why I am saying only tract lesion? Can I also not get it in radiation lesion and visual cortex? Yes or no, and why for each? Come on, quickly. So this is a question you will think and answer me. Right, meantime I am showing you the next slide. So this is your homonymous, I think you can understand this. So what is gone? Left side or right side? This is the left eye field, this is the right eye field. It is this is gone and this is gone, isn't it? So if this is gone and this is gone, it is left sided homonymous hemianopia. Okay, you have to remember that. And just keep in mind that if there is a left sided lesion, it gives rise to right sided homonymous hemianopia. In a right sided lesion, it will give rise to left sided homonymous. Okay, so once we know this, then we come to our next slide, which is this one. Actually it should be, the eye should be moving this way. What is this? So this is another feature of optic tract lesion, where you can get, write down, one eye up, one eye down, one eye up, one eye down, seesaw nystagmus. So learn with me, there is another feature of tract lesion, and that is seesaw nystagmus. Okay, Morris has tried to answer it, which is very good. So you have to understand this. What is the answer of this question is that if you look at your light reflex pathway, from the tract it goes to pretectal. So light reflex pathway is not coming down. Because it is not coming down, that means any lesion in the radiation or in the cortex, pupillary reactions are normal. Please remember, any lesion in the radiation or cortex, pupillary reaction will be normal. Make sense? Okay, we come to the next one. So next is, look at this one. Okay, first of all, very quickly I will come to look at the options. Most probable diagnosis is asking, and these are the different pupils given. So now I know what I have to search in the question. We will read the question. She is a 30 years old female presenting with complaints of blurring of vision while reading and photophobia in bright light. Right. So on examination there is anisocoria with large regular pupil in the left eye. Large regular pupil, anisocoria. Okay. Then what is the most probable diagnosis? Okay. So all of you, this is anisocoria. Difference of pupil size is anisocoria. We have to know this. Now when you talk about difference in the pupil size, first very interesting tip I am giving you, it is always a lesion of efferent pathway where you get anisocoria. So everybody remembers the pathway of light reflex pathway, I hope. Everybody remembers this, that if this is the left retina, right retina, right, and this is again equally divided into nasal temporal. So what did we say? That the light reflex path is going to come from the nerve, the chiasma, the tract, but then it is deviating to, again a simple depiction here, pretectal nucleus, and the pretectal nucleus will finally innervate both Edinger-Westphal nucleus. This is very, very important. Every pretectal innervates both Edinger-Westphal nucleus, and this is the cause of consensual light reflex that you get, right? So you are showing light in one eye, but you are getting the constriction in both eyes. Okay, so once we know this, what is the efferent pathway? We should be very clear. It starts from Edinger-Westphal ke baad third nerve, it goes to its inferior division, right? Then nerve 2 inferior oblique. Then it goes to ciliary ganglion. I hope you know this pathway. Then short ciliary nerves, and finally iris sphincter, right? So this is the efferent. So mainly it is the efferent lesion which is going to lead to anisocoria. That is one thing I have just said. So anisocoria, how do you want to approach? How are we going to approach anisocoria? This patient, sabse pehle, a very strong hint, she is a middle-aged female, large mid-dilated pupil, right, showing photophobia in bright light, anisocoria. We are talking about Holmes-Addy, right? So everybody, what have you answered? It should be Holmes-Addy pupil. Now why Holmes-Addy pupil? So how to approach anisocoria if we have to understand this? What will you say? Now you have to see that when you say anisocoria, so one eye, so the first thing that you have to understand is, are we the anisocoria is more in light or more in dark? More in light, or is it more in dark? So in this case it was more in the light or more in dark, whatever, right? So if I say anisocoria is more in light, which is the abnormal pupil? What do you expect the pupil to be in light? Constricted. That means the abnormal one is the one which is dilated, isn't it? So more in light means I will take care of, the abnormal pupil is the one which is dilated, right? So you will, what will you do? You will first, so that is the abnormal eye, go for slit lamp examination to first see Is it normal or not? So either I can see some sphincter tear due to some trauma, that is why the pupil is dilated. That could be one important cause. Any sphincter tear, this is going to due to trauma. Okay? But if it is not so, right, then if it is normal, what should be my next step? If it is coming normal, then why don't you try to constrict it? If I doubt Holmes-Addy, what should I do? Very small percentage of pilocarpine. So I am going to use 0.125% of pilocarpine and try to constrict this pupil. So once either it is constricting quickly, this confirms it is a Holmes-Addy pupil, right? If it is not constricting, okay, let me use a normal concentration of pilocarpine, that is 1% pilo. If it constricts, this is normal, we don't have to worry. If it is still not constricting, it means there is a mydriatic which has been put. So the answer here becomes pharmacological mydriasis, right? So this is how we approach this question. Okay, so that was about anisocoria, and this is how we approach. Now there are some other, what is Argyll-Robertson pupil? I hope you all know. ARP, accommodation reflex present, right? So here this is a condition where light reflex is absent and accommodation reflex is present. Generally it is happening due to lesion in the pretectal nucleus. Okay, done? Okay. So I hope you also know that ARP is also called light near dissociation. We call it ARP when it is mainly due to neurosyphilis. Keep noting down if you don't know, right? Yeah, neurosyphilis. Yes, very good. Then we talk about Horner syndrome. You all know it is lesion in the sympathetic chain, and we should also know what is Hutchinson's pupil. So let's see. Okay. So here what is shown, sometimes they will just give you this and they will ask you which type of abnormality is this. So you see here, when the patient is shown the light, so it is not reacting much with the light, but with the near reflex the pupil constricts. Now when this is reflex or the finger is even removed, it is still constricted, it will take time to redilate. This is tonic pupil or Holmes-Addy pupil. I hope you know this, na? This is tonic or Holmes-Addy pupil, right? So Holmes-Addy pupil or tonic pupil, everything is sluggish. Light reflex almost absent, accommodation is also very sluggish, and even sometimes tendon reflexes are sluggish. Pata hai na? Okay. And why it happens? Due to lesion in the ciliary ganglion or short ciliary nerves. So it is mainly efferent pathway. Okay. Okay. Next one. So this should be very, very clear to you. I included this slide to tell you that you have to revise this diagram very nicely. What is the pathway of the sympathetic chain? How it is starting from the hypothalamus, then there is a ciliospinal center of Budge, apex of lung, and therefore Pancoast tumor is one of the causes of Horner syndrome. You should know that, keep that in mind. Then superior cervical ganglion and how the postganglionic fibers through the cavernous sinus are finally innervating the eye. Okay? So this you have to know. To the finally it is going to innervate the dilator pupillae, sympathetic supply, right? Iris sphincter has parasympathetic and dilator pupillae has sympathetic. Okay, so we all know any lesion here will lead to what? What are the features of Horner's? A very quick revision here. Horner syndrome, we will know that it is meiosis, ptosis, we all know this, right? Meiosis, ptosis, and then enophthalmos. All of you, it is not an actual enophthalmos, it is mainly apparent enophthalmos. So I am neuro-ophtha, so I am taking it little in detail. After this, the other topics we are going to have a quick revision, right? So enophthalmos is apparent, dekhne mein lagta hai, it is not actual enophthalmos, right? Yeah. What else? So meiosis, ptosis, enophthalmos. Then we all know loss of sweating, anhidrosis, and loss of ciliospinal reflex. Okay, we come to the question. Question number 1, Horner's is best described by which two features? You should say meiosis and ptosis. Best described by meiosis and ptosis. Second question, very interesting, answer me. Is it congenital or acquired? Horner's is congenital or acquired? You should say both congenital and acquired. Okay? And how to differentiate that? Presence of heterochromia iridis, then it is congenital Horner's. If there is a presence of heterochromia iridis, it is congenital Horner's. Right. Yes, so talking about Hutchinson's pupil, what is this slide showing you? A very quick revision here. Third nerve palsy, if you remember, you have learnt that it can be medical or surgical, right? When you say medical third nerve palsy, means the causes can be diabetes and hypertension. Look here, we will draw the same thing along with me. You draw like this, maybe simplified manner. So the core is supplied by vasa vasorum, right? And in diabetes and other medical causes, this is actually affected first. But the pupillary fibers are mainly present on the dorsal side, the superficial part, right? Which is supplied by which blood vessel? Pile blood vessels, right? Therefore, when it is a medical cause, pupillary fibers are spared. This is very important in a diabetic third nerve palsy. Please remember there is pupillary sparing because of this reason, right? Okay, and any questions? Yeah, okay, so you all are answering good. Keep interacting. Then second important thing that you have to know, apart from this, what is Hutchinson's pupil? Suppose there is a surgical, as you can see there is a lesion here. Whenever there is any surgical cause, what happens? Initially the pupillary fibers are just getting, there is an irritation of pupillary fibers and there is meiosis. And a constant pressure there damages the pupillary fibers and later there is mydriasis. So this meiosis followed by mydriasis, this is what is Hutchinson's pupil. Got it? So Hutchinson's pupil jo hai, this is a mainly a feature of surgical third nerve palsy. It is surgical third nerve palsy. ठीक है? Okay. We next talk about is this question. Again, please, before reading the question, what did I tell you? The lesion is in. We will read the last statement. We will read the options. Optic tract, antechiasma, central chiasma. Okay, we have to focus on the chiasmal lesion. Now come back to this question. A middle-aged woman presented with the complaints of painless diminution of central vision in her left eye detected on routine eye examination. Also complains of difficulty in reading on examination visual. So just imagine you already start getting lost, right? So but try to focus. Middle-aged woman is mainly visual acuity in the right eye 6/9, but main problem is in her left eye where visual acuity is 6/24. Right? IOP is normal, we will skip this. Pupils show brisk reaction in right eye whereas left eye shows mild RAPD. There are mild lenticular changes, ये भी अभी फिलहाल important नहीं है. Visual field examination shows. Now pay attention. Centrocecal scotoma in left eye, superotemporal field loss in the respecting vertical meridian in the right eye. So now tell me, where is the lesion? I think everybody now knows what is the answer. So how do you answer this? Central cecal scotoma in one eye means optic nerve of that side is involved. That's why you are getting an RAPD in the left side. And superotemporal quadrantopia in the right eye. We are talking about, what is the answer all of you? I'll wait for the answer. Try to give the answer here. No, not A. We are talking about chiasmal lesion, isn't it? So our answer is anterior chiasma. Chalo, let us see how. I'll simplify this for you. See, you have learned just now with me what is bitemporal hemianopia where two nasal fibers decussate, right? So this is what is, यहाँ का भी temporal नहीं, यहाँ का भी temporal नहीं है, only the nasal. So this is bitemporal hemianopia. This is a feature of when both side nasal fibers are decussating, isn't it? So what do you call that? Central chiasmal lesion. This is central chiasmal lesions. This is one. So chiasmal lesions can be central, it can be anterior, it can be posterior. This was central, exactly at the decussation. Now what is anterior chiasmal lesion? This will explain to you. This was central chiasma. When this is gone, you get a bitemporal hemianopia, right? Now look at this one. Here is the lesion, anterior part of chiasma, involving some fibers of the left eye and few fibers of the chiasmal, the decussating fibers of the opposite side. Do you get me? What are these? Look at this one, you will know what are these. It is a normal anatomy that the inferonasal fiber of one side, when it is crossing the chiasma, detours to say hello to this other side, other optic nerve, and then crosses. This detouring and saying hello is what is called Willebrand's knee. And when the lesion is here, look at this one. Where is the lesion? The lesion is here only. So what is happening? It is involving the Willebrand's knee. So Willebrand's knee is what? inferonasal fibers. So what will be the field effect? Superotemporal quadrantopia. So central cecal scotoma with superotemporal quadrantopia, this is anterior chiasmal lesion, we call it anterior junction syndrome. And you know there is another name for this, you should know that also. It is called anterior junction syndrome, or you can call it, you can also call this junctional scotoma of Trecar. Okay, junctional scotoma of Trecar. Yes. Okay, so what is the answer? Anterior. And what happens in posterior? Posterior chiasmal lesion also, you understand what is posterior chiasmal lesion? Write it somewhere, let's write here. Posterior chiasmal lesion means mainly macular fibers involved. Okay, so what you see, only the macular area there is, but it is heteronymous, not on one side, one is on the left, one is on the right. That is the difference. This is macular heteronymous semianopia. This is a feature mainly of the posterior chiasmal lesions. Okay. I included this slide to ask you, what are you looking here? What are these field effects? What do you think? So this is what is called pi in floor, and this is what you know as pi in sky, isn't it? So what is pi in floor and pi in sky? Optic radiation fibers which are going through temporal lobe are inferior fibers. So any temporal lobe lesion will lead to pi in sky, superior quadrantopias. And very quick revision here, for parietal lobe se jo fibers ja rahe hain, so the radiation, so we are talking about optic radiation lesions. Very good, very nice Kavya, very nice Leo. So this is when it is from the parietal lobe lesion, any lesion at the parietal lobe, especially anterior part of parietal lobe, anterior part will lead to pi in floor. These are also incongruous. Remember, when it comes to posterior parietal, it becomes congruous. Okay? Okay. So this, you have to remember all this. We come to the next question. So it's almost impossible to speak everything in a revision session, but I'm trying my best to revise with you all as much as possible. So any questions you can ask. So part of the color vision pathway are all except. Are you all aware of the color vision pathway? So color vision pathway you all should know. So color vision pathway you all know will start with cones, isn't it? From the cones, passing through all the layers of the retina, it comes to ganglion cell. So first question has been, these are previous year questions for you, which ganglion cell is responsible for color vision? We will answer it is the X ganglion cell. From there goes to lateral geniculate body, again another question, which part of the lateral geniculate body? We will answer parvocellular layer. And from there it goes to layers of blobs of layer 2 and 3 of primary visual cortex. Okay? And from the primary visual cortex it goes to secondary visual cortex, and then to fusiform and lingual gyri. Fusiform and lingual gyri. Okay? So very quick, you should know what is the pathway. So the questions have been asked on ganglion cell, on LGB, and also on blobs of layers 2 and 3 of primary visual cortex. Okay? So what should you say here? Yes. Y ganglion cell will be the wrong one. Yes, so this is it. Nice. So color vision, everybody, we all know the trichromatic theory. A quick revision here. So blue short wavelength, green and long wavelength red. We all know this, that combination of all these three. So these are the larger cones, the medium sized cones and small cones together contribute to the color vision. Just remember that. And also we should know how to classify the color blindness. Quickly recap. What are trichromats? When there is only anomaly and weakness. When you say dichromats, one is totally absent. One exam question here, which is the most common color blindness? It is deuteranopia. This is most common. Okay, remember this. And monochromats is only when it sees all the colors of just grades of shades of grey, nothing else, right? So this is about your classification. Then I think recently this NEET PG only, last time they have asked you about your Ishihara chart. So you should know what it is. This is the Ishihara chart, right? And it helps to catch red-green blindness, I meant to say. Okay, so red-green, it is mainly to catch the red-green blindness. So you all know that if you are not color blind, you will be able to read the numbers, otherwise you will not able to read the numbers. This is mainly for screening purposes. And if you need to quantify the color blindness, which is even better than this, is this one. You should be able to recognize this. This is Farnsworth-Munsell 100 hue test. So this is Farnsworth-Munsell 100 hue test. Actually, there are not 100 hues in this. I don't know why they say 100 hue. There are mainly 85 caps of different shades of the same color. Okay? It's okay, Jayesh, part of the game. Yes, most sensitive. Then we talk about optic nerve head changes in, okay, so we are now, so before I go to this month, this topic of glaucoma, one more question I want to discuss, then only I will feel satisfied. Just give me 1 minute. Yeah, so we have talked about radiation lesions and all. What about the cortex lesions? Do you all remember that? Where should I write? I will write here only. So what are the cortex lesions? Visual cortex, we all should, very quick revision here. It is supplied by two types of arteries, posterior cerebral artery and middle cerebral artery. है ना? So posterior cerebral artery and middle cerebral artery, this is a separate disc. So you should remember this, that M for M, middle cerebral also mainly supplies the macular area, right? So if posterior cerebral is gone, this is the reason a macula will be spared. Someone was asking me about this, so I am repeating. Right? So macula is spared and the rest is gone. This is what is called macula sparing. The central spare, the shaded part means that is gone. So this is what is macula sparing homonymous hemianopia. Okay, na? When there is a blockage of posterior cerebral artery. Okay? And if middle cerebral is gone, it is not total macular. That is the interesting part. Be alert. If middle cerebral is gone, it is not total macular, because some branches of posterior cerebral also supply the macular area. It is a dual blood supply. So what is the condition where you get a total macular homonymous? When there is trauma. So the whole macular tip of the visual cortex is damaged, then you can get a macular homonymous hemianopia. Okay? Okay, and this macular sparing, you can also call it as keyhole vision, right? Sometimes, very rarely, both side PCA can also go. If both side PCA is gone, socho, is side B you will get macular sparing homonymous hemianopia. Again, what is now the vision of the patient? The visual field is only like a tunnel vision, and this is what is keyhole vision. So actually the term keyhole vision is used for both simply macular sparing homonymous hemianopia, or you can say both sided PCA lesion. Right? So this is your keyhole vision, not keyhole visual field defect. So this was another interesting question. Visual field defect keyhole, what should you answer? It is lateral geniculate body. Okay? So then the answer is lesion of, so keyhole vision, then it is occipital lobe lesion, and if it is keyhole visual field defect, it is a lesion of lateral geniculate body. Right? Okay. So we can now talk about, I am rubbing this please, now we can talk about is this next question. Let's quickly revise all these topics now. So optic nerve head changes in the glaucoma, we all remember that. Cup disc ratio change I have discussed. What is bionetting sign? Double bending, once it is out of the cup, then out of the disc, that is what is bionetting sign, right? Okay. Maurice, can you answer me this? If the question is asked to you, ring scotoma is a feature of, and there are two options, glaucoma and retinitis pigmentosa, what would you supposed to answer? Soch ke batao. Think and tell me. So my question to you all is, ring scotoma is a feature of, and apart from 4 options, 2 clashing options are glaucoma and retinitis pigmentosa. What will you answer? Tell me. Right. So whatever optic nerve head changes in glaucoma are all except. What is not present? What should be the answer here? Nasal step is not a nerve head change, it is a visual field defect. Common sense. It's a simple question here. Right? So we will answer this. What is Raynaud's nasal step? We will just talk about it shortly. Okay. So if you talk about the different changes, what you have to know for the fundus changes, I hope you remember. First, in my simple way of learning, you can just note down that one is cupping. Cupping means increase of the non-neuronal area, right? Then what else you can see? Some vascular changes. So cupping, then cupping will start, suppose this was the original cup. ऐसे करते हैं. Let me start like this. Suppose this was the normal cup, right? So initially it is inferior notching. Slowly, so this is called notching of neuroretinal rim. Everybody is clear now that this part is the neuroretinal rim and this is the central pale area, which is mainly the non-neuronal area which doesn't have the nerve fibers, and this is what is called as the cup area. Now what happens due to the remodeling of the lamina cribosa and damage of the nerve fibers, this non-neuronal area is increasing, which is called cupping. ठीक है, तो ये जो cupping धीरे धीरे this is going to extend and this will be like this. This is your cup. So first it was notching, now it is thinning of neuroretinal rim. Then you will see openings of lamina cribosa as laminar dot sign. Right? So let's see this. I think the slides will be a better thing. So here this is your normal optic nerve head with a CD ratio of around 0.3. Now here see, this is the glaucomatous cupping, very nicely shown. Come to the next one, again very nicely labeled. What is neuroretinal rim, what are the main vessels, what is disc, this is the cup area. INI-CET rule everybody should know that normally in all of us the distance of inferior, first is the distance that is the inferior part of the neuroretinal rim is the most wider or thicker part. Then comes your S, so INI-CET rule. I is more than S is more than N is more than T. Now what happens in glaucoma? It is first starting with inferior notching. So do you realize the INI-CET rule is broken, right? No, Morris, if they are asking you like this, tunnel vision is a late defect of retinitis pigmentosa, but earlier visual field change will be a ring scotoma. So what is this? It is a very clashing question and a confusing question, but you know glaucoma may, we call it double arcuate scotoma, also called ring scotoma. So if ring scotoma is given, we will first prefer retinitis pigmentosa. Early change is always ring scotoma in a typical retinitis pigmentosa because it involves the mid periphery. ठीक है, चलो अब हम लोग next slide देखते हैं क्या. So these are the, can you see the fenestrations here? These are the openings of lamina cribosa, laminar dot sign. This is another change of optic nerve head change. Okay, we come to the next one. This is what is double bending of vessels. One, it is out of the cup here. This is out of the cup, out of the disc. So double bending means as if it is coming out of a disc. The cupping has depth, right? So this is what is bionetting sign. This is your bionetting sign. Right. Now, once we know these changes, a few more that I would like to mention here. You should also remember the vascular changes में double bending के बाद nasal shifting. It is shown very nicely here. See, this distance that it travels, this is what is called nasal shifting of vessels. Again, nasal shifting is due to remodulation of lamina cribosa. The vessel which was entering straight gets shifted to the nasal side. So, nasal shifting of vessels, blood vessels. Okay. Yeah. So, these are the findings of optic nerve head. Come to the next question. So, then we will talk about the visual field effect. So, come to this question now. So, pick the correct statement. The field effect is arcuate scotoma of the right eye or arcuate scotoma of left eye. Enlargement of blind spot of left eye, enlargement of blind spot of right eye. Good, Morris. So, first we will look at this. Look at this one. What is this field effect, all of you? What is this field effect? So, do you know how to see the automated perimetry chart? We quickly see the grayscale, we quickly see the probability chart of the pattern deviation. Okay? And we will come to the, we come here to the diagnosis that this is the blind spot and there is enlargement of, there is the area of, this is increased. So, this is enlargement of blind spot, isn't it? So, if it is enlargement of blind spot of which side? Blind spot here is left side, no? So, it is a left eye. Just remember this is a quick tip. Otherwise, you should understand this, that when we are talking about the field chart, field is opposite of anatomy, disc normally is nasal, macula is temporal. So, in the field chart what happens? That it is the blind spot which is becoming temporal, right? So, naturally if whenever we discuss the field, you have to understand left ka left, right ka right. The patient is just sitting beside you, think like this. So, if the blind spot is temporal. What side, which eye is this? I think now it's clear, it is the left eye. So our answer will be C. The field effect is enlargement of blind spot of the left eye, right? Okay, what are the causes of enlargement of blind spot? Can you remember something? Enlargement of blind spot, a quick tip, one of course very important is papilledema, right? इसके अलावा you can learn with me about myelinated nerve fibers. ठीक है? What else? Myelinated nerve fibers, or it could be drusen's. So this can all lead to enlargement of blind spot. Okay, so if we talk and quickly want to revise the field effects in glaucoma, because again that is a very important topic and also thing that you all feel difficult about. It's very simple. You should know the concept of field. First of all, you know this. What are isopters? These are the points. If I join all the points of same sensitivity, we form an isopter. So it is the different axis in which we are testing the visual field. So again, my oversimplified way of showing it, what we can do here is, if suppose this is the visual field chart, right, and we are just showing the primary two meridians here, and this is the blind spot. You all know blind spot is between, this is exam question, blind spot is between 10 to 20 degree isopter. Okay, so look here, see. So when you say the blind spot, the physiological blind spot, it is between 10 to 20 degree isopter. So isopters are here, the sensitivity nasally drops very sharply, and in temporal side it drops little gradually, right? And this is how we depict. These are the isopters in a simple way, the circles, right? These are the different axes. Okay, so when I am talking about the visual field effect, do you all remember this? I expect that you all have studied this, that the first damage in glaucoma occurs in arcuate fibers. So what will be the first defect? Arcuate fibers are temporal, so field effect will be nasal, and because it is first inferior temporal fibers which are gone, inferior arcuate fibers are gone, so you get a, what do you get? Superior nasal field effects. So generally the first is scotoma in this area, and this is what is called Jerum's area. So this is an exam question. Where do you get the first visual field effect? You will answer paracentral scotomas in Jerum's area, right? फिर क्या होता है? The next story is that I am going to show you the slide also. First listen. The next story is it can join the blind spot, and this sickle shaped is called cedal scotoma, and then cedal scotoma slowly it is going to extend, and this will lead to superior arcuate scotoma. This is also called Jerum's scotoma, right? Now then the inferior arcuate will be formed, but it doesn't exactly abut, and this space is left. This is what is Raynaud's nasal step. Okay. So this is this inferior and superior arcuate scotoma, together we call it double arcuate or ring scotoma. ठीक है? Okay. So this is about your different types of scotomas, and what is the, slowly what will happen, even the central visual field will be involved, and what do you think is left behind? So this is the whole field. If I think it, I'll say the whole field is something like this. I have just shown you the central field defects, right? So what do you think? What is left behind after and before the blindness is only central island of vision and temporal island of vision. What stays till last? We will learn it is the temporal island of vision which stays till last, right? So let's see this. So here this is it. So if you look here, these are the field effects. This, I think you all are very familiar with this. We can skip this, and we have already drawn all this, right? So coming to, once you know about the field charts and the field effects in the scotoma, in glaucoma, now next thing that, so what are the two questions from the field effects is, which is the earliest field effect? That you will always answer Jerum's area, paracentral scotoma in Jerum's area. And secondly, if they ask you which is the last island of vision which is left behind, we are going to always answer is temporal. Okay? Okay. Next we talk about is this question. What is this investigation, all of you? I think we all know that this is a tonometry. Okay, so this has been your exam question. The question here is, what type of tonometer is this? We will answer it is a rebound tonometer. rebound tonometer, and the question is, it is used for, we will answer, self measurement. Mainly this is the tonometer which can be used for self measurement. So let's focus on the questions here. Okay, next question, which is more reliable, applanation or indentation? What do you say, applanation or indentation? Morris, this is not Perkins, this is rebound. So whenever you see supporting the forehead, it is a rebound. Okay. Yeah. This one, this is your Shiod's. So is Shiod's more, this is applanation tonometry, more reliable, or Goldman is more reliable? Goldman is always more reliable. Please remember this, right? So why it is not? Because reading of Shiod's depends on the scleral rigidity of the patient. It depends on scleral rigidity of patient. Okay. Okay, so this is another question on Shiod's. Then they have, this is your exam slide also, they have asked you this. What is this? This is your Goldman tonometer. What do you see in the Goldman? These are the two Myers, two semicircles. Our aim is to move the knob till the inner ends of both meet like this. Whatever reading there is, this is the intraocular pressure. So this is one of the gold standard, is always, even now it is Goldman. But can you tell me which is one disadvantage of Goldman? That the reading of Goldman also depends on the central corneal thickness. So please remember, if the central corneal thickness is more, if there is a thick cornea, we overestimate the IOP, and in a thin cornea, we underestimate. It's a very important thing. If for a workup of a case of glaucoma, we always see the corneal thickness. Correct? Okay. And which can be more reliable than Goldman, where this central corneal thickness is not an issue? Please remember the name. It is your DCT. है ना? What is DCT? Dynamic contour tonometry. Okay? This one is Perkins. This is your tono pen. So what are the questions for tono pen is, this is one tonometer which can be used in treatment. This is the choice for children or infants. After this is Perkins. First now tono pen. What will you use in infants or children? First you will now answer tono pen, then handheld version of Goldman is Perkins. Secondly, it can be used in scarred and irregular corneas. This is the next question here, scarred and irregular corneas. Okay, so we can come to the next one. This is your pulsar tonometer. This is the pulsar tonometer. Again, what are the non-contacts? आपसे पूछ सकता है, what are the non-contact tonometers? So non-contact tonometers, one is pulsar, second is your ear puff, and the latest one is ORA, ocular response analyzer. Ocular response analyzer. Right. And in this tonometer, what do you see? It is over the lids. This is diaton. It is on the lids. Okay. So this is diaton tonometer. Remember this. Okay. We come to the next question. So pick up the incorrect options here. All of you. What is an incorrect option in this? What are you looking out here is gonioscopy. I hope you have understood this. This is a gonio lens. So this is an indirect one because it is reflecting from the mirror, and then the patient we are able to examine, right? So this is how we see the picture of a gonioscopic view is this one. Okay, so pick up the incorrect options here. Does not require pupillary dilatation. So gonioscopy, does it require pupillary dilatation? No. So this is a correct option. This is a gonioscopy with direct lens. So this is the incorrect option because it is mainly indirect, as this is a reflected light. The refractive index of gonio lens is more than air? Yes. So this is why we are using it. You know na principle of gonioscopy? Normally, why can't you see the anterior chamber and angle structures through your slit lamp? Because of total internal reflection. So if you remember your principle here, that when you go back to your physics, that when the light is coming from the denser to the rarer medium, what happens? It is Actually, normally what happens, at one angle, you keep increasing the angle of incidence. At one point at the critical angle, it will be perpendicular. Now, any angle more than critical angle, it totally internally reflects, right. So, what you are doing? You are trying to make the medium more denser outside by giving a gonio lens. That is what you are doing. So that there should not be internal, total internal reflection, the light rays should come out, and so that you are able to see. Okay, at this point, one exam question for you all. What is the critical angle in the cornea? Critical angle of cornea. What will you answer? You will say 46 degrees. Okay? So, this is 46 degrees. Yeah. So, I think this should be better than Goldman, where your corneal thickness is not an issue, is your, as I said, your DCT, that is dynamic contour tonometry. We also call it Pascal's tonometer, that is Pascal's tonometer. Okay, so you know the answer, you know this is what I have been explaining. This is total internal reflection, but when I use a gonio lens, the light ray will come out. Correct? Yeah. Okay, so we next talk about is what is the side effect of which drug is shown here. So, we are now talking about anti-glaucoma drugs. Almost always a question on anti-glaucoma drugs in every exam or every year. So, what are you looking here are these deposits, right. So, we are talking about alpha agonists, right. So, this is the answer here will be epinephrine. Okay. So, what are the other, if you talk about brimonidine, what is the side effect of brimonidine? It causes drowsiness, remember this. Brimonidine can lead to drowsiness. Yeah. And latanoprost, it causes, the eye in which you give, you all know there will be iris pigmentation. So, conjunctival pigmentation, then it is not latanoprost. Conjunctival deposits or pigmentation, you will answer is alpha agonist, that is epinephrine. But latanoprost, it is causing iris pigmentation, it becomes darker iris and leading to difference in iris color, that is heterochromia iritis, right. Okay. And pilocarpine you cannot give in uveitis. And what are the effects of pilocarpine? I hope you know, it causing constriction shallow anterior chamber, and when it is causing spasm of ciliary muscles, it can lead to myopic shift, right. So, these are the side effects. Okay. So, here what is this slide showing you? This is the heterochromia iritis. So, in which eye there must have been latanoprost given is darker, right. Okay. What is this showing you? This is also a side effect of PG alpha analogues, and here you can see hypertrichosis, okay, right. So, this is hypertrichosis. What is the side effect in this one? Can you realize this is your lid retraction, right. So, lid retraction means when the lid is above its level. So, this is seen where it is mainly again prostaglandin analog. No, wait, not prostaglandin, please do not learn this. So, lid retraction is mainly a side effect of apraclonidine. Let me correct myself, this is apraclonidine, right. It can lead to lid retraction. So, we are talking about selective alpha agonist, brimonidine, apraclonidine. Yeah. And what do you see here? So, this is the drug deposit in a whirl-like manner. What do you call that? Vortex keratopathy, isn't it? So, vortex keratopathy, which anti-glaucoma drug can cause? The new one, netasodil. You know, this is the new anti-glaucoma drug, and this netasodil can lead to vortex keratopathy, right? Yeah, it's apraclonidine, yes. Yes, Neelam, yes, Morris. So, then we talk about after netasodil, what are the other causes? I hope you remember other causes of vortex. Vortex keratopathy is also called cornea verticillata. What are the other causes? We should also revise this: chloroquine, then amiodarone, right? Then tamoxifen and Fabry's disease. Okay. Okay. We come to the next feature. All are the features of pigmentary glaucoma except. You remember pigmentary glaucoma generally in the young males due to the rubbing of the iris at the back, because the configuration of iris is more posterior. We call it reverse glaucoma. We also call it reverse glaucoma. So, there is a lot of pigment dispersion, and this pigment dispersion will lead to this type of this trans illumination defects, isn't it? More light is passing where the pigment is gone. So, this is what is trans illumination defects. Right. So, let us solve the question first before I see the slides. So, all are features except trans illumination hota hai, blurring vision after exercise, yes. Then Sampuli's line, what is Sampuli's line? Again the pigment and anterior to the Schwalbe's line, that is pigmented line is seen, that is on gonioscopy. Okay. So, line anterior to Schwalbe's line on gonioscopy. This is what is Sampuli's line. And what is Hudson-Starley line? This is nothing but iron deposition. Okay. So, you can make the diagram and understand here. It is the iron deposition at the middle and lower 1/3 of the cornea. Generally idiopathic. This is what is called Hudson-Starley line. Right? Okay. So, you just saw what is trans illumination defects. So, this is your thank you, God bless you, let us keep focusing. So, this is what? This is the pigments which are seen on gonioscopy, which is a dense deposition of pigments, and you can see this in pigmentary glaucoma also, and you can see it in pseudo exfoliation syndrome as well. Okay? So, this is nothing but pigment deposition. This is the pigment deposition. Okay. So, this is another feature of pigmentary glaucoma. Come to this question, let us solve this one. Phacolytic glaucoma occurs due to, do you all know which is the answer? A, B, C, D? I would like you to answer. This is a very, very easy question. So, phacolytic glaucoma, tell me, occurs due to which cataract? What are the different cataracts? I hope you understand these are cataracts. So, which type of cataract is it? So, this one I think is a mature cataract. I would write here mature cataract. Okay, what will I write here? This is which one? This is Morganian cataract. Can you see the nucleus dancing in the liquefied cortex? So, this is Morganian. Okay, which is this one? These are radial spokes. We also call it cuneiform cataract. You know? These are the radial spokes that you see. Most commonly, this is the form of cataract we see in the senile type. And here I see the nucleus is involved. So, this one is your what? Nuclear cataract. So, this one will be the nuclear cataract. Now, can we answer? Phacolytic is a complication of? Answer will be B. Yes, very good. You all are answering good. Keep learning, Mehul. This is all we have to know in ophthalmology. Enjoy this class. Okay. Then we talk about is, after this, what is the next question? Chalo, batao. Which lenticular opacity diminishes the vision most? What will you answer now? This is again a very simple question. All those heavy topics are over. Retina, neuro-ophthalmology, glaucoma. Now, answer me this one. Which lenticular opacity diminishes the vision most? Can you tell me? Which one will diminish the vision most? It is PSC. Pupilliform cataracts are nothing but posterior subcapsular cataracts. Okay. So, this causes maximum diminution of vision. Chalo, few more questions on PSC. Most common complicated cataract, PSC. Okay. Okay. Next, another question. Most common radiational cataract is also PSC. Right? And you are already learning that it causes maximum diminution of vision. Okay. What will be the best way to see a PSC? Is it slit lamp or distant direct ophthalmoscopy? You will say distant direct ophthalmoscopy is even better than slit lamp. Okay. So, to see the PSC. Right. Okay. I think there was one more question on PSC. I'll tell you when I remember. So, this is the answer of this question. Posterior polar cataract, can you remind me what is one very important point about posterior polar cataract? This onion peel, this way, onion peel appearance. Okay. So, it is adhered to the posterior capsule and it is very tricky to operate. It was a very high chance of causing posterior capsular tear. Right. And I hope you remember for nuclear cataract we have learnt about second sight of old age, which is nothing but improvement of near glasses. Right. So, these are important questions. Why does that happen? You know na, nuclear sclerosis. So quick revision with your nuclear sclerosis, that is hardening of nucleus, refractive index increases, more refractive index means more power. Therefore, I need lesser power in my specs and there is therefore improvement in the glasses. This is called second sight of old age. So, it is due to index myopia, isn't it? So, when I'll just draw this to explain you first and then second sight of old age. So, when there is a nuclear sclerosis, the index increases and therefore, for my specs I need lesser number here, right. So, this is a feature of nuclear cataract where you get second sight of old age. So, these are the questions on nuclear cataract, posterior polar cataract, cuneiform, cupuliform, right. And this is the posterior capsular cataract through the slit lamp that I am seeing. Can you see this opacity? This is all PSC. Yes. Yeah, we are looking at the images only all together. Vishal, so many images I am showing you in every question in and around only images. Now we come to this one. True association include all except catch, which is not the true association. Let's see. Wilson's disease, sunflower, yes. Myotonic Christmas tree cataract, yes. Alport's posterior lenticonus, is it a yes? No, we get anterior lenticonus here. Okay? So this is the correct answer. Is this? So ye wrong ho gaya na association. And Down syndrome mein blue dot cataract again is yes. Okay, images for you all. Vishal, where are you? So images. So look here. This is the slit lamp light which is falling on the lens, and here what you see is a posterior lenticonus. Kahan milta hai? Posterior lenticonus, where do you learn? Exam question. Loeys syndrome. Remember this? Loeys syndrome is oculocerebrorenal syndrome. Oculocerebrorenal. Okay? Okay, we come to the next image. Look here. This time, can you see it is the anterior surface where there is anterior lenticonus like this. Okay? So this is anterior lenticonus. Chalo, batao. What are the questions on anterior lenticonus? Let me solve with you all. They have asked you it is more common in males or females? More common in males. Remember that. Okay? Secondly, what are the, where do you get it? So you will answer Alport syndrome, which is familial hemorrhagic nephritis. We all know this. Also in Waardenburg syndrome. Okay? Also in Waardenburg syndrome. Yaad hai Waardenburg? All of you? I'll show you what is oil drop. Okay? Then you will know why this is not oil drop. I don't see any oil drop in this. It's a lens section which we are seeing, and I can demarcate that this is the anterior part, this is the lens, this is the posterior part, and we see it is this. I'll show you how to actually diagnose oil drops. Okay? Wait. Okay. Uske baad fir next we talk about is after this anterior lenticonus, come to this one. So this is what you were asking, isn't it, Morris? So look here. So Waardenburg, I was talking first about Waardenburg. Waardenburg, if you remember, white frontal log, joint eyebrows, right? So vestibular dysfunction. Similarly, what you get in eye, you get poliosis, you can get heterochromia iridis. If you want to note down, please note down. So Waardenburg, we get poliosis is graying of eyelashes, then heterochromia iridis, anterior lenticonus, okay, and telecanthus. What is telecanthus? Far away medial canthus with normal interpupillary distance, because it's a soft tissue problem. In hypertelorism, the two medial walls are far apart. Therefore, this time what you get is hypertelorism mein IPD is more. So this is also exam question. What is the difference between telecanthus and hypertelorism? What are you getting in Waardenburg is telecanthus. Okay? Okay. We come to the next. This is what is oil globule reflex. So with when you are looking in the line through which you are looking the slit lamp and the illumination, when both limbs are almost in the straight line, you can see the back front does glow as you are seeing in this case. This whole thing is called, view is called retro illumination view. So in retro illumination, this is what you see, this is oil globule reflex. Again, important point, this is a feature of anterior lenticonus. Okay? Now, once we are talking about oil globule reflex, what are the other oils we know? So, there are three oils you have to know. One is this one. Second is oil droplet cataract. Okay, we will see that also. Oil droplet cataract. Now, your answer should be galactosemia. There's another question on galactosemia. This is one cataract which can be considered reversible. Otherwise, cataracts are not reversible. This will be one cataract which can be reversible. And what is the third oil we learn? Oil droplet reflex. So when you say oil droplet reflex, now we are talking about keratoconus. Again, the look is almost like the same Gola oil droplet, but this time it is by distant direct ophthalmoscopy. This is important to remember. Okay, let me see, I must be having some slides here. If not, you can just have a look at it, or you can just request me, I'll post on the Insta. Whatever slides we are missing, we can talk about that on the Insta, no problem. Okay, then we talk about, see, yeah, so a few slides which I have just included for your revision. So this is complicated cataract was again this year's last NEET PG question. Complicated cataract, the opacities are breadcrumb, and when you see so much colored view, this is what is called polychromatic luster. Polychromatic luster. Posterior polar image nahi tha Morris, that was posterior lenticonus. Oil droplet is totally different, in a different view with a broad slit and seen in retroillumination where you can see the background fundus glow. Then, and of course you cannot just comment like this, you have to associated history and finding of the patient, and then you will say this is which oil. Okay, everything has to be collaborated. ऐसे नहीं बोलते हैं, right? Otherwise by look you may get confused. Which is this type of cataract? See again images, Vishal. What is this type of cataract? This is what is single lamella is involved. So this is a lamellar cataract. Okay. So lamellar cataract, what are these? ये क्या दिख रहे हैं हमें? These are called riders. It's an exam question. Riders are nothing but additional opacities on the cataractus lamellae. These are riders. Another question. Lamellar cataract occurs due to which vitamin deficiency? You will say vitamin D deficiency. It is due to vitamin D deficiency. Okay? Okay. What is the next? Look at this one. This is what is your blue dot cataract, right? So blue dot cataract, we are revising the images here. This is mainly, you should know, most common congenital cataract, you will answer is blue dot. Another question was that can be seen in Down syndrome, this blue dot cataract. That's it. These 2 points you have to remember. Okay, what are you looking here now? This is what is rosette shaped cataract. So rosette shaped cataract is a feature of blunt trauma, which is concussion injury or blunt trauma. So this is again the slit, as you can see, and this opacity under this is your rosette shaped cataract. It is a feature of blunt trauma. Okay? A question on. This starts from which part of the lens? You will answer starts from posterior cortex. It starts from posterior cortex. What are you now looking at? Can you answer me this? Tell me, what are you looking at? Just give me the diagnosis. I'm skipping, I'll wait for your answer. This one is what is called Christmas tree cataract. Okay, needle-like opacities. These are Christmas tree cataract. Now you may get confused with sometimes with the polychromatic luster, but of course the background history will always support you. And other findings will help you to know. Where do you get Christmas tree? We all know myotonic dystrophy. We are talking about myotonic dystrophy. It's an important exam question, you should remember this. Shield cataract. What do you mean by shield cataract? Shields the pupillary area. So shield cataract is a feature of, again an exam question, we will learn atopic dermatitis. It's a feature of atopic dermatitis. Very good. Yes, Jan Donald, you have answered correctly. This one is your Vossius ring, imprint of iris on the anterior surface of lens. This is what is Vossius ring, right? Feature of blunt trauma. Can you tell me another feature? We talked about rosette shaped cataract, Vossius ring, Berlin's edema, which is also called commotio retini, edema at the macula. That is also a feature of blunt trauma. Okay. We then talk about next. See this one. One of you were asking me about oil globule. Look here. This is what is oil droplet cataract. You will almost get the same look for oil droplet reflex But you will know this is a patient of keratoconus, you are getting it by distant direct ophthalmoscopy. Here this is a patient of galactosemia where you through the slit lamp, when you look at, you are going to get this type of picture. Okay. So this is your oil droplet cataract. This is oil droplet cataract. Okay. What is this? This has been again exam question, very important. We all know we are talking about calcosis. Some people pronounce it as chalcosis. Okay, I prefer to call it calcosis. It's okay, both are correct. So what do you see here? It's a copper deposition, and this is what is your Kayser-Fleischer ring, right? And this is a sunflower cataract, Kayser-Fleischer ring and sunflower cataract. Okay, all of you, Kayser-Fleischer ring, I am quickly revising this if you want to note down. So Kayser-Fleischer ring is mainly starting from above, below, and then makes a circle. That was one option and it is correct. Second, where is the copper deposited? We all know Descemet's membrane. Third, all patients of Wilson's disease with neurological complications, almost all will have KF ring. But hepatic disease patients, not all patients present with KF ring, only 67 to 70% will present. And that was the wrong statement in one of your questions. So these are some important facts about Kayser-Fleischer ring you should know. Okay? Now what is Fleischer's ring? ये तो Kayser-Fleischer है. Fleischer is exact the same spelling, but this time it is iron deposition. Where is iron deposited? Epithelium. Always irons are deposited in epithelium, remember. And it is seen in keratoconus, right? So this is again, if I make a Fleischer's ring, you can draw a simple diagram in my way, that this is your keratoconus and this is iron deposition at the base of the cone in patients of keratoconus. This is what is called Fleischer's ring. Okay? And come to what is you are looking out here, again the same, that is sunflower cataract. This is a sunflower cataract. Chalo. Acute infectious endophthalmitis after cataract surgery, all except. Acute infectious endophthalmitis, all except. So it is usually associated with decreased visual acuity, of course, maybe painless, painless. No. The patient is complaining of a lot of pain, redness, photophobia, diminution of vision, and no fundal glow. So this is it. Okay. Most commonly it is due to, yes, this is correct. Early onset it is staph epidermidis, and late onset is, what is the late onset cause for endophthalmitis? I hope you know. We will learn propionibacterium acne, right? And if this option is not given, the next option will be fungal. So you should know this. And most common fungus here, again it will be, the most common fungus here would be Candida. Right? So for most common fungal infection for orbital cellulitis is mucormycosis. Remember that, for orbital mucormycosis, and it's an important topic after COVID, right? You should know this. Yeah. Then we talk about is, and is it associated? So what is the answer here? This is the wrong statement. Okay? Okay, one more question on endophthalmitis. What is the treatment of choice? Yes, very good, Ayan, you have answered correctly. So, tell me, what is the choice of treatment of endophthalmitis? You will see the vision. If vision is better than hand movement, then of course it is intravitreal. If you want to note down, it is intravitreal antibiotics. Hai na? So, then that means generally we go for ceftazidime and vancomycin. And if it is less than hand movement or so, then you will have to go for surgery in pars plana vitrectomy to remove and clear that. So this is a case of endophthalmitis. We see hypopyon, corneal edema, lot of redness, no fundal glow. So this is what is post-operative endophthalmitis. Okay, and this is the most common long-term complication of cataract surgery. So what is this? Now you will answer, this is most common long-term complication of cataract surgery. This is your PCO, posterior capsular opacification. What do you also call it? After cataract. And what is one very important question here? What is the treatment of choice of after cataract? You all should know, Nd:YAG laser, posterior capsulotomy. Nd:YAG laser, posterior capsulotomy. Right? Okay, we come to the next question. All are causes except, I think this is already discussed. We have just listed what is the answer is chlorpromazine. Please remember chlorpromazine, they are deposited on endothelium. So these are endothelial deposits. Okay? Okay. Then we talk about is, next we talk about the next question is, identify the incorrect statement. The reading in the above instrument is affected in. What is this instrument all about? This is a aesthesiometer. Okay. So what is this? This is aesthesiometer. Lecture I'm going to, in details will not be possible, but yes, some part I am going to take tomorrow. We have one more session tomorrow, we will take that part. Just give me 1 second. Okay, so this is this was about aesthesiometer. So they are the reading in the, this is what I have given the question here is that reading in the above instrument is affected in. What will you answer? So we are trying to ask you here, क्या पूछ रहे हैं? What am I asking you? What are the causes of decreased corneal sensitivity? Okay, can it be glaucoma? Don't be misled. Yes, it can be in absolute glaucoma where there is which is a painful blind eye. Okay, neurotrophic, you all know when the fifth nerve is gone we get a neurotrophic keratitis. So again, yes, leprosy, yes, and viral keratitis, of course there is decreased corneal sensation. So answer here is bacterial. It is asking you will affected is the reading in the above instrument is affected in incorrect statement. Identify the incorrect. The question is incorrect. So it is not affected in, it is not affected in bacterial. In all the other, these are all the causes of decreased corneal sensation, all of you. Please read the questions very carefully before answering. Chalo, come to the next one. Okay, what is this? This is an important exam question. They have asked you what is specular microscopy. We all know specular microscopy is a method to examine the endothelial cells. So it's a method where we can see how many cells there have, what are the number of cells and how many have polymegathism and pleomorphism. So all of you, what is the normal number of endothelial cells? We learn anything from 2500 to 3000 cells per millimeter. Please remember it's not cube, it's square, per millimeter square. Okay? And then they will ask you about keratoplasty mein, for keratoplasty or for corneal graft, what should be the minimum number of endothelial cells in the graft that I will say, okay, yes, this can be used as a graft. So you should preferably answer 2000, but we can also answer 1500 if 2000 is not in the option. Both are in the option, I will answer 2000. At least this much of the endothelial cells should be there for me to take it as a graft. You shouldn't be using a graft where the endothelial cells have been damaged too much. Okay, we come to the next one. So what is this? Pachymetry. This is also exam question. Pachymetry is mainly used for, we all know, thickness of the cornea, to measure the thickness of cornea. Right? Very good, Nikita, that's a correct answer. Yeah, minimum 1500 is also not a wrong answer, Sam. That can also be, sure, that can also be correct answer. Actually, not exact values are given in different sources. Huh? Of course, what is this? Can you see this? Any idea? These circles? Topography. So we are talking about corneal topography. Right? Again, to measure the, scan the whole surface of the cornea to see where it is steep, where it is flat. Now, coming to another Vishal, another image question for you. These ocular manifestations are of which drug? Can you think and tell me? These ocular manifestations are of which drug? So let's see the ocular manifestation first. What is this? Slit lamp light falling here. These are the opacity. So we are talking about posterior subcapsular cataract. Right? Look at this one. This is what you were waiting for. Alternate areas of hyper and hypopigmentation. Bullseye maculopathy. So hypo is due to damage of the retinal pigment epithelium, hyper is due to the drug deposition. So there is a dark and light area. This alternate dark and light area is what is a bullseye maculopathy, isn't it? This is what is bullseye maculopathy, and of course this is vortex. So can you answer me what is the drug? Yes. Can you answer me what is the drug? Very good. Yeah, Chandra, it is C, chloroquine. Okay? What are the causes of bullseye maculopathy, all of you? Bullseye maculopathy, you should know this, very important. So you can draw it for yourself, that it is alternate areas of hyper and hypo, dark and light. This is what is bullseye. Okay? So you will say chloroquine, also hydroxychloroquine. Even this is a cause of bullseye maculopathy, and cone dystrophy. Okay? Yeah. We come to the next question. At a 33 years old male patient. So first of all, let me go to the last statement to see what they are asking. Which of the following drugs would be effective in him? Doxycycline, sulfamide, vancomycin, PHMB. Okay. Let me see what is the diagnosis. A 33-year-old male patient complaining of pain, watering in the right eye. On examination, a corneal ulcer is seen with elevated margins and feathery ends, hyphae. Everything is given. It's already written hyphae. And this was exact statement of one of your exam question only. This one I haven't made this question, this one. So this was exact question. So others of course I have, but not this one. And hypopion. So hyphae hai, fungal hai. Which is the antifungal which is mentioned here? So you should know silver sulfadiazine can be used as an antifungal. So answer here is silver sulfadiazine. Okay. This is what we are trying to check with you. This is also called keratomycosis, isn't it? Keratomycosis. Few questions. Which is the most common fungus infecting the cornea? We will answer Aspergillus fumigatus. It is Aspergillus fumigatus. If this option is not given, next best option will be Fusarium. We will answer Fusarium. Right? Okay. And then they ask you signs are more or symptoms are more compared to bacterial. So you will answer signs are more than symptoms, isn't it? Signs are more than symptoms. Yes, drug of choice, Maurice, will be natamycin. That's correct. When they ask you the drug of choice, we will answer natamycin only. Right. And they have also asked you so many times, why do you get a fungal corneal ulcer? I hope you know it is mainly trauma by vegetative matter or organic matter, like with a leaf or a twig. Okay? Okay. So we next come to the next question here. So this is what? Can you see the hyphae? This is what we are talking about, fungal keratitis. Of course, one more very important question. Why don't you make this diagram to quickly revise this on examination, right? So what do you see? First of all, we will learn that ulcer has a dry and rough look, right? This is a dry rough ulcer, okay? And then there are feathery ends, these are hyphae. Then another question is on hypopion. Fungus can penetrate the cornea, go inside the anterior chamber. So it's an unsterile hypopion. In bacterial it was sterile, remember this. Unsterile hypopion is exam question. And some more lesions apart from the main lesions. This is a repeated question. When it is a repeated, I make a double Q. So this is called satellite nodules. These are satellite nodules. Okay? So these are satellite nodules. So this was about your questions on fungal keratitis. Again, what is this? This seems to be more like a bacterial keratitis. I can even see a hypopion here. There is no hyphae or anything, but it's a central corneal ulcer. Most probably this is bacterial ulcer, right? See how much area is all involved. The patient will not be able to see anything in this. And which one is this one? Superficial punctate keratitis. We are talking about herpes simplex, herpes zoster. In both the cases you can get this involvement, right? So we are talking about viral keratitis. So what is the pathognomic feature of viral keratitis? If they ask you, please don't say dendritic ulcer. Dendritic ulcer is not a feature of zoster. So you will say decreased corneal sensation. Okay? Yes, dendritic ulcer is a feature of only simplex keratitis. And very important, if you see ends are knobbed ends. This is asked. So you will say it a dendritic only when there are knobbed ends like this, right? So this is your dendritic with knobbed ends. So that means, and when it is going to progress further, it can lead to geographical ulcer. In simplex, if we have by mistake given steroids, it can lead to, so this one is your, see all images Vishal, so this one is your geographical ulcer. Yeah. What is this? This is a question for you all, a quick answer here. Look at the slide. What are you looking at? Answer me this. Okay, I'll wait for your answer here. Move to the next one. What is this? This is a ring ulcer of acanthamoeba. Okay, ring ulcer or ring lesion ulcer of acanthamoeba. So acanthamoeba keratitis, you should know that it can invade the nerves and therefore it is very, very painful. It causes perineuritis. Okay, one point. Second important point, what is the drug of choice? You will say PHMB, polyhexamethylene bigonides. Third, they have asked you about culture media, non-nutrient agar with E. coli. These are the three questions on acanthamoeba. Pain is too much. There can be thickening of nerves also because of the inflammation. I said one is this, and of course very, very important, it is a rare infection. It is not common, but it happens due to contact lens use, right? So soft contact lens user washing their lenses with tap water. This is the reason of having acanthamoeba. So I have shared 3-4 very important recurring questions of your exams. Okay, please remember. So choice of treatment, PHMB, culture medium, non-nutrient agar with E. coli, and of course after contact lens use. But suppose the question is, which is the most common infection after contact lens use? This is rare, I said. Then your answer will be Pseudomonas. Most common infection, you will answer Pseudomonas. Okay, Chandra, have you answered this for my question here? This is what? This is a, very good. This is no knob dents. Can you see any knob dents here? No. This is a pseudodendrite. It is not dendritic. These are pseudodendrites, and therefore we are talking about zoster. It's a feature of herpes zoster. Okay? Yeah. What are you looking at now? What is this? This is your salmon patch, pink patch of bleeding seen in interstitial keratitis due to, as far as salmon patch is seen in syphilis. This is due to syphilis, right? So this is what is salmon patch. Once this has been your exam question, you should know what is interstitial keratitis kya hai? When epithelium and endothelium are not involved, only the stroma is involved. That is what is interstitial. I generally make this diagram to show if this was the epithelium, this is the endothelium, this is the stroma. So only stromal involvement, right? Where you can get a patch of bleeding. So if you want to draw a diagram like this for yourself, it will help you. This is what is salmon patch. Okay, we come to the next one. What do we have? Yeah. So let us read this. All are true regarding the condition in the figure below except. What is the condition in the figure below first? What are you looking at? This is a case of scleromalacia perforans, where the scleritis is a necrotizing scleritis causing thinning of the sclera, exposure of the uveal tissue, and it has become ectatic leading to ciliary staphyloma. What is staphyloma? Ectasia. So initially it was a scleritis which has led to staphyloma. Okay? So it's a case of scleromalacia perforans. So if it is a case of scleromalacia perforans, we have to, all are true regarding the condition in below except. Which is the wrong statement for this? Now can you answer me? What will be the wrong statement? It is common in females, correct. It is a ciliary staphyloma, correct. It is common in rheumatoid arthritis, yes, and it's an important question. Remember, it is generally seen in patients with rheumatoid arthritis. It causes perforation, no. It looks like it will perforate, but it doesn't perforate. It is only when the intraocular pressure is high that it may perforate. So it does not cause. So this will be the wrong statement. Yes, yes, Dr. Guitarist. This is a good combination. So if you play guitar, then you should really share this, how you're playing guitar and all. You know? Some extra hobbies are very, very important for our relaxation. So I am very happy to know if you are a guitarist. Huh? So anyway, so all are true regarding this condition. Did you get me? And ciliary staphyloma, when I am talking about, a very quick revision of staphylomas means ectasia, and this ectasia, make this diagram, can be from the cornea, then this is anterior staphyloma, right? If it is from the limbal area, this is limbal area. इसको बुलाते हैं intercalary staphyloma, isn't it? If it is from the ciliary body area, we call it ciliary staphyloma, then equatorial staphyloma, and finally posterior staphyloma. ठीक है ना? Right? And your exam question, which is most common? Posterior. Okay. Why does it happen? Generally you will answer pathological myopia. It is happening due to pathological myopia. You all know myopia with fundus changes. Anterior staphyloma most commonly due to pseudocorneas, right? ठीक है? And of course for ciliary staphyloma main cause is scleritis. One we have just read as scleromalacia perforans, or it could be trauma. Equatorial again scleritis we will learn. Intercalary we will learn peripheral corneal ulcer. So this was a quick revision. Okay? So question has been asked about which is the most common, and it has been asked regarding scleromalacia perforans. Okay. So what is the diagnosis? Let us look at this. Sabse pehle what are you looking at? Ultrasound B scan. This is the lens, right? Look at the surface of this retina and the choroid. Normally it should be like this, but this is like this. What is it? Yes, it is posterior staphyloma. So the answer here is, this is a case of posterior staphyloma. So posterior staphyloma is very clearly seen by ultrasound B scan, right? Okay. I think this way I've already described it to you everything, so you will answer this very nicely. Identify the incorrect statement. So pathognomic of Wilson's disease, correct. Seen in the superior desmus membrane, yes. Seen in all patients of neuroinvolvement, yes, but not in all patients. So this is the wrong, right? And disappears with desferoxamine, sedating agent, right? So what is the answer? Which is the wrong statement? That all patients of hepatic involvement may not have case of Fleischer ring. So this has become a very favorite topic. Last 3 years they are asking, INI-CET ho, chahe NEET PG, they are asking you this. Okay. Okay, so which is not seen in keratoconus? Which is not seen in keratoconus? All of you. Munson sign you all know, V-shaped deformity of lower lid. Okay, scissors reflex on retinoscopy. You see two light reflexes like two limbs of the scissor. So that is your scissors reflex. What is Habs stria? No, it should be Vogue stria. Habs stria kahan milta hai? Congenital glaucoma. It is stretching of inelastic membrane is the descending membrane. So what happens if you want to draw for yourself? Draw it. So when you say generally it is made horizontal or circular. These are Habs stria. And in keratoconus what you get, it is parallel to the steeper axis, isn't it? So these are the Vogue stria. For keratoconus, this is the Vogue stria. And of course, keratoconus causes irregular astigmatism. We all know that. We'll talk about astigmatism in the tomorrow's session. Okay. So this is what is your Munson sign, right? So this is your Munson sign. We all know this in keratoconus. Yes, very good, Sarika, Neelam. It is congenital glaucomatous. Yes, all of you have answered correctly. Look, this is the Fleischer's ring I was talking about. We are seeing in the cobalt blue filter, which is iron deposition at the base of cone in keratoconus. Okay, then we come to this one. This is, see, almost same as oil droplet cataract, वैसा ही लग रहा है. Difference is, this is a case of keratoconus. I am seeing through distant direct ophthalmoscopy. This becomes your oil droplet reflex. Okay, on distant direct ophthalmoscopy. And these are the Vogue stria. Okay, these are Vogue stria which are vertical. What is this? These are prominent corneal nerves. Because of thinning of the cornea, you know in keratoconus we can get prominent corneal nerves. Right? So again, this was Habs in congenital glaucoma. Look, this is what is Habs. Right? So this is Habs and this is Vogue's. Very nice comparison here. Okay, we come to this question now. Tell me, this is the last question. And again an interesting question and a lot of common mistakes here. So constantly changing refractive errors are seen in which cataract? I will leave it to you now. This one you can answer. No, Morris, it is not painful. Absolutely not painful. The only pain the patient will have is he is not able to see clearly, but actually it is not painful. Okay. What is the answer of this question? Constantly changing refractive error is seen in. Soch ke batao, please. So what is the answer of this question? Yeah, this is the last one. Yeah, tell me. Okay, some of you are saying, Rakesh is saying B, Morris is B, and some people are saying intumescent. So the answer is intumescent. Let's see why not B. Okay, so what are the causes of constantly changing refractive errors? Learn with me like this. Early cataract, late glaucoma, diabetes. Can we write this? So early cataract, late glaucoma, diabetes. This is factual that in late stage of primary open angle glaucoma, you may get frequent changes. Early cataract, it is mainly intumescent we are talking about. In this stage, you all know there is imbibition of water which can vary, sometimes less water, more water. When it is more water, the lens is swelled. More swelling, more curvature means more power. That means towards myopia, myopia is more power. And when there is less water, less curvature, it is going towards lesser power. So this change of refractive status is frequently changing in intumescent state. And the third cause is diabetes. So it's not diabetic cataract, it is diabetes disease per se which is causing this. How? When there is hyperglycemia, okay, when there is hyperglycemia, more sugar, it is causing swelling of the lens. Swelling of lens, as you know, will cause myopic shift. And when it is so, hyperglycemia will lead to myopic shift. And in hypoglycemia, this is going to lead to hypermetropic shift. Hypoglycemia will lead to hypermetropic shift. Okay? Am I clear to you all now? So you have to be understanding this. It is not diabetic cataract, but it is diabetes itself which is causing frequent change of glass. So here our answer will become intumescent. I told you I will not give a simple question. Right? Okay, so I think that was all, and you can ask your doubts here, right? Any other questions? I am always in touch. I think you enjoyed the session. We are going to meet again tomorrow at 12 to finish off with squint and optics and discussions on these chapters. Okay, so come well prepared. Whatever the chapters are remaining, just revise it so that you can really have a benefit of discussing with me, right? Okay, thank you so much. Thank you.